Okay, shall I start? Okay. Hello, welcome to all for this month's webinar symposium, organized by Venkat Center with support from academic grant from Glowderma. My sincere appreciation to them for supporting this academic event. As you are all aware, this was an effort to teach the subject of aesthetic dermatology systematically and scientifically, as per the syllabus of Rajiv Gandhi University of Health Sciences. Now, this year, we have changed the format. As you are aware, we already had one session, and that is we used to have once a week. Now we have once in a month in an extended manner. So today is the discussion on botulinum toxin, something of great relevance and interest to most dermatologists. And as per this program, we are going to have discussions on basic aspects of botulinum toxin, which will be discussed by Dr. Amrita. Then we will have a presentation by our fellow Dr. Nikita on botulinum toxin for upper and mid phase. And then we have botulinum toxin for lower phase, neck and other areas, which completes the different indications for botulinum toxin. So the fellows will discuss the basic aspects, the basic sciences aspect, and the simple aspects of injections, etc. But we also will have an advanced discussion with the help of three experts. One is Dr. Rajat Kandari, who will discuss botulinum toxin, lower phase, neck and other areas. He will also show a video of it. Then Dr. Rasya Dikshit will have a lecture on, will show a video on botulinum toxin for upper phase and also discuss tips for successful botulinum toxin practice. How to get successful in it, which is something which is very interesting for most young doctors. Dr. Aniket will join for the panel discussion and he will present a plastic surgeon's view of botulinum toxin. So we have designed this in a way that it will be of interest to both the residents, young graduates, postgraduates, and then those with some experience also. So I hope everybody will enjoy it. So now we'll have the first video, and that is by Dr. Amrita. Can you please play the first video?
Sir, shall I introduce?
Yeah, before that, I hand over the mic to Team Glowderma for their customary announcements. Now, just to introduce here, please go ahead. We'll introduce the speakers. Dr. Rasya Dikshit is a very prominent dermatologist from Bangalore, very experienced in the field of aesthetic dermatology. As you can see here, she is currently the website committee chairperson. She was also the media cell chairperson. She has received Presidential Appreciation Award in 2022 and in 2021 from Karnataka President, and her area of interest is aesthetic dermatology. She has written chapters in publications and has had a number of publications in different conferences, national and international. Next we have, next slide please, Dr. Rajat Kandari, who is a dermatologist from Delhi, and he has been a very prominent face in aesthetic dermatology. He has more than 60 publications in textbooks, journals. He is the associate editor of JCAS and IDOJ, and also Journal of Cosmetic Dermatology. She has been the vice president of Delhi State Branch of IDVL and secretary of Delhi State Branch. He was the recipient of Imrit Sarkani's scholarship and the fellowship award of EADB Rising Star Scholarship in WCD. He has been the coordinator for SIG Aesthetics in 2024 and convener in 2022. So he is a very prominent face, very experienced in this field. We welcome him to this event. Next we have Dr. Aniket. There is something wrong here. He is not an MD from, I think this is totally wrong. We'll ignore this. Dr. Aniket is a plastic surgeon. He is not a dermatologist. And he is, take off this slide, please. Good. Yeah. Dr. Aniket is a plastic surgeon at Venkat Center, having passed his MCH plastic surgery from St. John's. And he has done a number of fellowships from Turkey, from Belgium, and several centers in United States. His area of interest is not just aesthetic injectables but also surgery, particularly rhinoplasty. And his perspective is very important as he's a plastic surgeon. These two specialties are closely related, and we have much to learn from each other. So I welcome all the experts, and we'll meet all of them at the later part of this program when they come for their presentations and the panel discussion. So I request all of you to be ready with your questions and keep putting it on the chat, and we'll take them. So there will be adequate time for discussion. That is the whole basis of this program. Now, there is something more I want to say. This program is open only for dermatologists and plastic surgeons. So anybody wanting to register will be asked to sign a declaration that they are a qualified dermatologist or a plastic surgeon. And then if the information is found to be false, we will not allow them from subsequent webinars. This we have done because there has been many instances wherein non-dermatologists have tried to join or tried to sneak into our conferences, including Dermacon. So we want to avoid that. We are limiting it to only qualified dermatologists and plastic surgeons. So thank you very much. Now with these remarks, I hand over the mic to Team Glowderma, who will have their customary announcements and then play the videos by the three fellows. Thank you very much.
Good evening all. I am Rohit Kotade. I am working as a product executive at Glowderma. Glowderma and Venkat Center welcome you all for the Glowderma Venkat Center Symposium Season 4 in association with Venkat Center. I would like to thank you to Dr. Venkatram Mysore sir to giving an opportunity associated with this Venkat Center, and thank you to all experts to bring this program. Now, Glowderma. So at Glowderma, through elevating lives, and our core value is to meaningful innovation, unwavering commitment to quality and safety, continuous improvement, and result through teamwork. Also, we have an aspiration core value that is customer success above all else. Glowderma have a 7+ first-time Indian brands and 400+ enterprising Glowdermians and 113th rank in pharma company. We have a 700+ distribution channels and 9,000+ associated with dermatologists. Glowderma have a skilled R&D team and develop innovative formulation. Glowderma have a product mix like an antifungal, moisturizer, and acne care and hair care. Also, we have a psoriasis care, topical steroid, vitiligo care, and nutraceuticals. Glowderma, also known as for India's first company to make all product paraben-free, sulfate-free, and detergent-free because patient safety is of paramount concern. Glowderma have a flashy brand that is Moist, the most advanced moisturizer and cleanser. Moist, we have a Moist cleansing lotion, Moist LMF48 lotion, Moist cream, Moist and Moist XL. Glowderma have a ketoconazole range that is Kion, the advance of solubilized ketoconazole in lipid phase. In Kion, we have a Kion Stay On lotion, Kion soap, Kion zip, and Kion tablet, and Kion cream. Glowderma have a hair care range that is a minoxidil, Minoboost and Minoboost F, the topical hair solution formulated with a lipid base and enriched with Procapil. Minoboost containing 360-degree spray applicator and dropper. Glowderma is the first time India in novel non-fluorinated topical quinoline Ozodex that containing ozonioxin cream and lotion. Ozodex, the move on the Zen next. Glowderma have a tie-up with the Sanosun Baby that is made in German brand that is a premium pediatric skin care. So Glowderma have a tie-up with the Man & Shoulder, the bring world-class derma test certified with a natural and safe baby skincare product in Indian mothers. Sanosun Baby is German's premium baby skincare with a one global one formulation with a 14+ years of experience in baby skincare and presence in 70+ country. Sanosun has gained the trust of confidence 250,000 mothers, Indian mothers. Sanosun Baby is made with more than 90% natural ingredients, 0% SLS free, and it is a clinically tested by hypoallergic. Sanosun Baby with a milk protein and organic olive oil. So all participants can download their e-certificate with a valid email ID with a submit and download e-certificate. This is the e-certificate for lecture 2, that is the botulinum toxin. So please note all the recorded version of Venkat series 1, 2, and 3 is available on glowderma.digiconnect.com, and also season 4 Glowderma Venkat Center Symposium is available on glowderma.digiconnect.com. So that's all about the Glowderma. Thank you so much. Thank you, sir. Sir, shall I play the video?
Play it, please.
Yes, sir.
Good evening, everyone. I am Dr. Amrita Solanki, a fellow in aesthetic dermatology at Venkat Center. Onset, I would like to thank Dr. Venkat sir for giving me this opportunity. I would also like to thank Glowderma for giving me this platform for presentation. So I'll be presenting on basics of botulinum toxin. So the scope of my talk is introduction and history, microbiology, manufacturing, pharmacology and mechanism of action, immunology, formulations, practical methods, indication and contraindications, patient assessment and counseling. Introduction. Botulinum toxin injections are among the most popular, minimally invasive aesthetic procedures worldwide. Often referred to as the miracle toxin, it is one of the most potent and deadly substances on earth. History. Early observations. 10th century, Emperor Leo VI of Byzantium linked the blood sausages to paralytic disease, botulism. 18th century, botulism outbreaks during the Napoleon Wars due to the poor food preservation mistakenly attributed to cyanide poisoning. Scientific discoveries. In 1820s, Dr. Justinus Kerner studied botulism, experimented on himself and documented neurological symptoms from contaminated sausages. In 1928, Snap and Sommer purified botulinum toxin, paving the way for research. In 1949, Arnold Burgen discovered its mechanism, blocking acetylcholine, leading to paralysis. Medical advancement. In 1960, Dr. Edward Shantz successfully purified botulinum toxin type A. 1973, Dr. Alan Scott used botulinum toxin to treat strabismus in monkeys. Cosmetic and therapeutic use. In 1992, Jane and Alistair Carruthers observed wrinkle reduction in the patients treated for blepharospasm. In 2002, FDA approved it for glabellar lines. In 2004, they approved it for hyperhidrosis, forehead wrinkles, and lateral canthal lines. Coming to the microbiology, botulinum toxin is isolated from bacterium Clostridium botulinum. It is an anaerobic gram-positive spore-forming bacterium which is present naturally in the soil, plants, static water bodies, and GI of mammals and aquatic life. Botulinum toxin is broken into 7 neurotoxins labeled from A to G, which is structurally similar but antigenically as well as serologically distinct. Type A is the most potent, followed by type B and type F. Type A, B, and E are the most common causes of human botulism. Serotype A and B are the most widely used in the medical and aesthetic treatments. Molecular structure. Initially synthesized as a single chain 150 kDalton molecule, cleaved to form a di-chain structure linked by disulfide bridge. Coming to the manufacturing, the process used for manufacturing botulinum toxin is similar to what was used historically to produce the wine and other biological products. As you can see in this picture, in the cell banks, the Clostridium botulinum is cultured. In the upstream, the toxin is been extracted. It is been purified in the downstream. It is then formulated to the final product. Coming to the pharmacology, it is composed of polypeptide chain, heavy chain that is 100 kDalton and light chain that is 50 kDalton. Heavy chain functions are the N-terminal domain translocates the light chain, the C-terminal domain binds to the nerve cell receptors for endocytosis. The disulfide bond links the heavy and the light chain, maintaining the toxin potency until activation. Coming to the therapeutic formulation, botulinum toxin consists of botulinum toxin per se and excipient. The toxin consists of neurotoxin and non-toxin proteins. Coming to the non-toxin proteins, they are protective but catalytically inactive. They dissociate immediately upon the injection at physiological pH. The excipient consists of stabilizers, that is albumin, sucrose, gelatin, lactose, and dextran, and buffer system that maintains the pH balance during the storage and use. Coming to botulism, botulism is a rare but serious emergency condition because of the excess of botulinum toxin in the body. There are 4 types of botulism. foodborne, infantile, wound, and animal-borne botulism. It does not cross the blood-brain barrier, so it does not affect the CNS. However, the botulinum toxin causes the generalized muscle weakness, leading to the trouble in breathing, slurred speech, trouble swallowing, droopy eyelids, blurry vision, and weak muscles. Coming to the mechanism of action, botulinum toxin prevents the release and the action of neurotoxin acetylcholine, thus preventing the contraction of muscles. The steps and mechanism of actions are: once it is injected into the muscles, it diffuses towards the nerve endings in the fluid environment. The C-terminal of the heavy chain binds to the polycyanoganglioside receptors on the presynaptic membrane, forming a receptor complex. The toxin is then internalized via the endocytosis using the ATP pump. The botulinum toxin A binds to the synaptic vesicle protein, while the botulinum toxin B binds to the synaptotagmin receptor. Inside the cytoplasm, this disulfide bond between the heavy and the light chain is cleaved, activating the toxin. The light chain consists of zinc-dependent protease, which cleaves the SNAP25, a key protein required for vesicle docking and neurotransmitter release. The snare complex disruption. The snare complex consists of SNAP25, syntaxin, synaptobrevin, is essential for acetylcholine vesicle docking and release. The botulinum toxin serotype ACE cleaves the SNAP25, whereas botulinum toxin serotype B, D, F, and G cleaves the synaptobrevin. This prevents the acetylcholine release, leading to the muscle paralysis. Therefore, the effects are: the botulinum toxin reduces the wrinkles caused by the muscle contraction, but is ineffective for those due to the volume loss or photoaging. The effects are temporary and reversible. Acetylcholine, because the acetylcholine synthesis and storage remains unaffected. However, the recovery from botulinum toxin happens because of three mechanisms. One is the metabolism of the toxin in the body, the neuronal sprouting, the new nerve terminal formation, the receptor adaptation, the extrajunctional acetylcholine receptor develop. The effect on CNS. The botulinum toxin indirectly affects the CNS via the retrograde axonal transport, leading to reflex inhibition, normalization of reciprocal and intracortical inhibition, and modulation of somatosensory evoked potential. It can improve the spastic gait. Coming to immunology, the repeated exposure to botulinum toxin can trigger an antibody response, leading to its effectiveness over time, limiting its effectiveness over time. Antibody formation is rare. There are two types of antibodies: neutralizing antibodies, which reduce the efficacy, whereas non-neutralizing antibodies do not affect the efficacy. The factors that influence the neutralizing antibodies are the genetic factors. Some patients develop antibody against the different toxin components, the manufacturing and formulation. The 150 kDa botulinum toxin core is inactive. Reducing its presence lowers the antibody formation. The botulinum toxin A, the 95% is nicked before the release, reducing the immunogenicity, whereas botulinum toxin B is not nicked before the release, increasing its exposure to proteases and immunogenicity. The frequency and dosage. The doses more than 250 units and frequent injections, that is less than 12 weeks apart, increases the antibody formation risk. The cosmetic versus non-cosmetic use. Cosmetic treatment requires lower doses, potentially reducing the immunogenicity risk. Coming to the formulation, there are two formulations. One is the serotype A and B. The A are ONA, ABO, INCO, and Pro botulinum toxin, whereas serotype B is Rima botulinum toxin, which is approved for cervical dystonia. Coming to ONA botulinum toxin by company Allergan USA, the trade name is Botox. The molecular weight is 900 kDa. The shelf life is 2 to 3 years. Dosage form is in the spray dried powder. Excipient human serum albumin, sodium chloride. The pH is 7.4 and it is US FDA for moderate severe frown lines, glabellar and lateral canthal lines. It is available as 50 and 100 units per vial. Coming to another ONA botulinum toxin by company Meditox, trade name is Neuronox. Molecular weight is 904 kDaltons. This shelf life is 3 years. Dosage form is freeze-dried lipophilized preparation forms. Excipient is human serum albumin and sodium chloride. It is available as 50, 100 and 200 units per vial. Coming to abobotulinum toxin by company Ipsen Biopharma Limited UK. The trade name is Dysport. Molecular weight is 500 to 900 kDalton. The shelf life is 2 years. Excipient human serum albumin and lactose. pH is 7.4. US FDA approved for moderate to severe globular lines. It is available as 300 and 400 units per vial. Coming to incobotulinum toxin by company Merz Pharma Germany. Trade name is Xeomin. Molecular weight is 150 kDalton. Shelf life is 3 years. Dosage form is freeze-dry powder. Excipient human serum albumin and sucrose. It's available as 50, 100 and 200 units per vial. Coming to prabotulinum toxin by company Dovo Pharmaceutical Korea. The trade name is Jur and Nabota. Molecular weight is 900 kDaltons. Shelf life is 3 years. Dosage form is vacuum dried powder. Excipient is human serum albumin, sodium chloride. pH is not disclosed and US FDA indication is moderate to severe globular lines. It is available as 50, 150, 100 and 200 units per vial. Coming to rimabotulinum toxin by company US World Med USA. Trade name is Myoblock or Neuroblock. Molecular weight is 700 kDalton. Shelf life is 2 years. Dosage form is sterile solution. Excipient is human serum albumin, sodium chloride and sodium succinate. pH is 5.6. US FDA indication is cervical dystonia. It's available as 2,500 units per 0.5 ml. 5,000 units per ml and 10,000 units per 2 ml. Coming to units of botulinum toxin activity. Botulinum toxin is measured in Botox units, abobotulinum toxin as PUD units, incobotulinum toxin A as units. A mouse unit is the toxin dose lethal to 50% of 18 to 20 grams of female Swiss Webster mice via the intraperitoneal injection. These units are not interchangeable due to the variation in murine assay designs. Coming to the reconstitution of botulinum toxin, all the products are in powder form and require reconstitution. The preferred diluent are normal saline without preservative. The other options are preserved saline with benzyl alcohol. It does not affect the efficacy, reduces the injection pain. Lignocaine with epinephrine reduces the discomfort, no impact on efficacy or safety. Bupivacaine provides the pain relief while maintaining the efficacy. Sterile water, effective but causes significant pain. Saline with hyaluronidase enhances the diffusion while maintaining the efficacy. Albumin may allow dose reduction without compromising the effectiveness. When adding the saline, direct the needle bevel towards the vial wall to minimize the bubble formation. Coming to the dilution guidelines, Botox 100 units has to be diluted in 1 to 8 ml saline to form 12.5 to 100 units per ml. Dysport 300 units can be diluted from 0.6 to 2.5 ml saline to get 120 to 500 units per ml. Myoblock ready-to-use liquid can be diluted up to 6 times. The higher the dilution and larger volume may cause increased diffusion to unintended areas, reduce the duration of action, suboptimal clinical outcomes. The Onna to Inco to abobotulinum toxin A is 1:1:3 dose equivalence. Coming to the dilution instruction for Botox, 100 unit per vial has to be diluted in 2.5 ml preservative-free 0.9% sodium chloride to get 4 units per 0.1 ml. Similarly, 50 units per vial has to be diluted in 1.25 ml of preservative-free 0.9% of sodium chloride to get 4 units per 0.1 ml. Similarly, for Dysport, for 300 unit per vial, you can dilute it from 0.6 ml to 3 ml to get about 50 to 10 units per 0.1 ml. And for 500 unit per vial of Dysport, you can dilute it from 1 to 5 ml to get about 50 to 10 units per 0.1 ml of Dysport. The storage and shelf life. Onna A, Abo and Prab A has to be stored at 2 to 8 degrees Celsius. Incobotulinum toxin can be stored at 25 degrees Celsius. Reconstitution, once it is reconstituted by Arora et al., Botox has to be used within 4 hours, abobotulinum toxin has to be used within 8 hours, and Inco has to be used in 24 hours. The stability by Hexel et al. On botulinum toxin with preservative-free saline, no efficacy loss was seen when stored at 4 degrees Celsius for up to 6 weeks. Coming to the indication of botulinum toxin, the basic indications are for forehead lines, glabellar or frown lines, and crow feet. The advanced indications are for bunny lines, nasal tip elevation and dilatedness, and gummy smile. It is also used for perioral rhytids, labiomental crease and mentalis. It is also used for platysma bands. Cosmetic enhancement procedure. It is used for eyebrow shaping and masseter hypertrophy. The non-cosmetic uses are for focal hyperhidrosis, hypertrophic scar and keloids, post-herpetic neuralgia. Coming to microbotulinum toxin therapy. The injection depth of microbotulinum toxin is the multiple intradermal or subdermal injections into the overlining skin and superficial facial and neck muscles. The objective is to deliver tiny blebs of the toxin superficially, reducing the sweat and sebaceous gland activity, improve the skin texture for a smooth and lustrous appearance, mild muscle weakening for subtle aesthetic effects. As you can see in this picture, the microbotox is placed just above the muscle. Coming to the indications, it is used for total facial rejuvenation. In the young patient from 20s to 30s, can be used to prevent the dynamic lines, reduce the pore size, neck rejuvenation. Older patients suitable for those with weak musculature, prone to ptosis, corrects the crow feet in volumized cheeks, improves the excess upper eyelid appearances. The other uses are axillary hyperhidrosis and extended crow feet correction. Coming to the dilution technique, depends upon the treatment area. Double dilution, they draw the desired unit from standard 2.5 ml dilution and add equal amount of saline. In the triple dilution, similarly, you have to dilute by twice the quantity of saline. And microbotox by Wolf's Wu technique, draw 0.1 ml of standard dilution into a 1 ml syringe, fill the rest with the saline. The upper forehead, glabellar lines and the crow feet, the intramuscular injection with double dilution is preferred, whereas the lower forehead, infraorbital area, the triple dilution for the softer effect. Coming to the contraindication, the absolute contraindications are hypersensitivity to any component of botulinum toxin, the infection at the injection site, pregnancy and lactation. Relative contraindications are neuromuscular disorders like myasthenia gravis and Eaton-Lambert syndrome, the use of certain medications like aminoglycosides, penicillamine and calcium channel blockers. Coming to patient assessment guidelines, the assessment has to be done in optimal lighting, ensure the clear assessment of the facial anatomy and muscle movement. Patient positioning has to be seated upright in a comfortable chair for accurate evaluation. Makeup removal, essential for precise assessment of the skin texture and lines. The handheld mirror is used which allows the patient to visualize concerns and accepted results. Comprehensive 3D assessment has to be done to examine the frontal, lateral and 45-degree angles. Photographic documentation has to be done in the rest and in motion, understanding the patient expectation and align the goals with achievable results. Thorough medical history has to be done to identify the contraindication or factors affecting the outcomes. Detailed informed consent to ensure the patient awareness of the procedure, risk and expected effects. During the assessment, the muscle mapping has to be done to identify the origin, insertion and interaction with the adjacent muscles. The range of the movement has to be evaluated. You have to palpate the muscle to assess the tone, identify the asymmetries, check for the ptosis, evaluate the brow, eyelid and the cheek or the lip ptosis, screen for palsy, assess the volume loss and infection to rule out the contraindication, dose modifiers, adjust for age, muscle mass, prior treatments or neuromuscular conditions, consider the superficial vessels, minimize the bruising risk, Assess at rest and motion. Observe the dynamic and static wrinkles. Ethnic and gender variation has to be assessed so that to adapt the approach for the anatomical differences. Coming to the counseling part, you have to educate the patient that the goal is a soft, natural look and not to completely disappear all the lines. The dynamic lines can be treated with botulinum toxin, while the static lines require different treatment. Botulinum toxin cannot treat the skin sagging, loss of dermal elasticity, or volume changes. The patient relying on expression for work, especially the actors, we have to provide the thorough counseling on dosage. The timing of the treatment, schedule according to the patient activity and needs. Important events. Avoid injecting a patient the day before a significant event. Allow at least a week for adjustments or touch-ups before the event. These are my references. Thank you.
Thank you. Thank you, Dr. Amrita. That is an excellent talk. Very exhaustive on all aspects of basic sciences part. Now we have the next video by Dr. Nikita, which will be on the upper face, mid face indications to Botox. Please play the video by Dr. Nikita. Thank you.
Good evening, everyone. I'm Dr. Nikita, fellow student in Venkat Center. So I'll be continuing with the further discussion on botulinum toxin of upper and mid face. Before starting with the presentation, I would sincerely thank Dr. Venkat sir for giving me this opportunity and extend my gratitude to Dr. Aniket sir for his valuable guidance in preparing the presentation. We will be dealing with following subheadings, that is muscles of upper and the mid third of the face, as well as injection techniques, and gradually going into microbotox in brief. So as we all know, face is divided into upper 1/3, middle 1/3 and lower 1/3. I'll be dealing mainly with the upper 1/3 and the middle 1/3. So coming to muscles of upper third, so it is mainly the glabellar complex made up of procerus, corrugator, supercilii, and along with that there is frontalis and orbicularis oculi. Corrugator supercilii originates from the medial supraorbital ridge of the frontal bone and then inserts in the skin over the mid-brow. It helps in movement of the eyebrow downwards and medially, forming vertical lines. So procerus is a pyramidal shaped muscle which is originating from the periosteum of the nasal bone, then the dermis of the glabella. It helps in moving the eyebrow medially and leads to horizontal lines later. Coming to orbicularis oculi, it is mainly divided into three parts: orbicular part, orbital part, palpebral part, and the lacrimal part. Orbital part is the one which we are most concerned about. So it originates from the medial palpebral ligament and the orbital margin, and insertion wise it forms concentric loops around the eyes, inserts into the origin, extends beyond the rim, orbital rim, into the eyebrows, temple and the cheeks. It helps in mainly forced closure of the eyes. Then the lateral part mainly helps in depression of the lateral eyebrow, and inferomedial part help in pulling up the cheeks. Next is the frontalis muscle, which mainly causes horizontal crease lines over the forehead. It originates from the galli-aponeurotic layer and gets inserted along with interdigitating with procerus, corrugator and orbicularis oculi near the brow. It mainly helps in elevation of the brow as well as retraction of the scalp. So these are few variations of the frontalis muscle. The type 1 is full, where the muscle is present throughout the forehead. V shape, where central V lack of area of the muscle is seen. Then type 3 is central, where muscle fibers are predominantly present over the central area and lacking over the lateral area. And type 4 is lateral, where only lateral forehead has the muscle fibers. Coming to injection of the glabellar complex. So frown lines, these are vertical and horizontal lines between the medial brow and gives angry and tired look. Here we are targeting muscles like corrugator supercilii and the procerus, and muscles to be avoided are the portion of frontalis lateral to the corrugators. Coming to injection technique of the procerus, a line drawn from medial end of the brow to the contralateral medial canthus. So the injections are made at the point of the intersection of these two lines or just below it. The injection is always towards the forehead. 4 to 10 units can be given deep muscular injections. Then coming to corrugator superciliary, it has to be done within the safety zone. For the tail of the corrugator, it is given 1 to 2 centimeter above the supraorbital ridge at the lateral border of the corrugator. The needle should be pointing away from the globe and half of the needle should be inserted and superficial injections are given. And coming to body of the corrugator, it is given 1 centimeter medial and inferior to the previous point, which is closer to the eyebrow. Needle should be pointed towards the procerus muscle and it should be deep muscular injection. These are few variations where injection points can be decided based on the dynamic lines present in the patients. So first is the V pattern, U pattern, then omega pattern, pattern in converging arrows, and pattern in inverted omega. Coming to few points to be remembered, holding procerus and medial corrugators with non-dominant thumb and index finger helps in better placement of the injection and also prevents diffusion. Then supratrochlear vessels lie medial and close to the head of the corrugators. Pressure on the rim will reduce bleeding as well as seeping into the globe. Then do not cross the mid-pupillary line. Unwanted effects can be eyelid ptosis, where upper eyelid drops 1 to 2 millimeter, obscuring the upper iris margin. Diffusion also along the orbital septum, leading to paralysis of the levator palpebrae superioris can occur in this. So it mainly occurs due to faulty injection technique or high volume, large doses or very fast injections. It occurs within 48 hours to 10 days. Correction is mainly by stimulation of the Muller's muscle with the help of aproclonidine and phenylephrine. 1 to 2 drops 3 to 4 times a day can be given. It gives mainly symptomatic relief. Next, coming to forehead lines. So these are transverse lines. It can be either single or multiple of varying lengths present over the forehead. Target muscle here is the frontalis, and injection has to be avoided if the patient has eyebrow ptosis, upper eyelid dermatochalasis. Coming to the technique, so it has to be again given within the safety area to prevent eyebrow ptosis and to preserve the shape of the eyebrow. It is given intramuscular, raising a wheel and mashed with the thumb after the injection. Jacob's ladder configuration or staggered distribution can be used. So these are the injection point which can be seen in the picture. 1 to 2 units can be given at each side of 1 to 2 centimeter apart. Needle should be at an angle of 60 degree pointing upwards. Total of 10 to 20 units can be given in women and 12 to 24 units will be needed in men. Points to be remembered are always stay above 2 centimeter above the eyebrow. Avoid low lateral part. Small amount to be injected to the procerus to avoid brow ptosis. Harmonious result will be seen if frontalis and brow depressors are treated together. If treated separately, depressors should be treated first and then frontalis with a gap of 2 weeks. Distribute the injection based on individual muscle action. Then never inject the entire frontalis because it is the only brow elevator, gives a frozen look. Then short forehead. If the patient has short forehead, then stay high and single line injections are preferred. Unwanted effects can be brow ptosis, which occurs mainly due to too low injections. It can be either unilateral or bilateral. It can just be a lowering or complete flattening of the eyebrow. It can occur only over the medial, lateral or an entire eyebrow. Correction is mainly by treat the brow depressors, which may elevate 1 to 2 millimeter for medial. Then treat superior lateral orbicularis oculi part for lateral ptosis. Then there can be Spock eyebrow, where if the injections are concentrated in the center and the lateral fibers remain unopposed, it gets accentuated during speaking and animation. Correction is mainly by 2 to 3 units at the peak of the Spock can be given just medial to the temporal fusion lines. Then frozen look mainly occurs due to over-treatment of the frontalis. Correction is not being aggressive and low doses are preferred. Then eyelid ptosis can also occur due to inferior placement of the injection at the lateral limbal line. Occurs due to diffusion to elevators of the upper eyelid. So these are again few variations which can be given for frontalis, that is total pattern, medial pattern, lateral pattern, lateral pattern with prominence on the upper right and the left side, and lateral pattern with right side. 121 technique is a new technique for botulinum toxin where multiple vertical and horizontal lines are drawn. So medial canthus, lateral canthus, vertical line and central pupillary line on both the eyes, and central midline passing through the glabella. Horizontal lines start, the red line starts from the lowest frown line, then the highest frown line on the being the white line. In between them, there is a green line which is equidistant from the green and the white line. All the intersection points are given with 2 units. Coming to lateral canthal lines, also known as crow's feet. So these are radial creases from the lateral canthus to the temple, target muscle being the lateral portion of the orbicularis oculi muscle. Muscles to be avoided are laterally zygomaticus major and the minor muscle, and medially levator labii superioris, alecinasi, and levator anguli oris has to be avoided. Technique again being the safety zone. 1.5 centimeter lateral to the lateral canthus is the safety zone, and injection has to be given into the crease. So it is superficial subdermal injection raising a bleb. 2 to 4 units per crease is required. Modified crow's feet line treatment is mainly when the crow's feet line lie below the lateral canthus. So first injection is like conventional injection, that is 1.5 to 2 centimeter lateral to the lateral canthus, and the second injection point is antero-inferior point which is lateral to the line drawn vertically from the lateral canthus and superior to the maxillary prominence. The third injection is midpoint between the first 2 points. Points to be remembered here are caution should be taken if lower third of the canthal fold is being treated. Then if snap test positivity is present, then it can lead to ectropion or accentuation of the eye bags. History of dry eye should be taken before the treatment. Then needle should be always pointing away from the globe. Stay outside the vertical line from the lateral canthus. Redundant skin around the lateral canthus, if present, lower injection should be avoided. Unwanted effects like lip ptosis or asymmetrical smile can occur, where inability to close the mouth and drooling can occur. Injection below zygomatic arch leading to paralysis of the zygomaticus major and minor is the main reason for this. Correction is mainly avoidance. Then cheek ptosis and droop can occur due to 2 medial injections. Then fixed smile can occur due to overcorrection. Then accentuation of the wrinkles over the lateral cheeks due to redundant skin over the lateral canthus. Complications related to eyes can be worsening of the festoons, lagophthalmos, diplopia, ectropion, xerophthalmia, bruising, or pinpoint ecchymosis can be present. Then photophobia and impaired blink reflex can also occur. Next is infraorbital wrinkles. Here we are targeting preseptal orbicularis oculi muscle. Indications being young patients with hypertrophic preseptal orbicularis or accentuation of these lines after treating crow's feet, and to give a wider appearance of the eyes. So first we'll talk about the medial lower eyelid. So injections are always subdermal, raising a wheel. Ask the patient to close the eyes and muscle should be relaxed. A line drawn from the mid-pupillary line 0.5 centimeter below the inferior eyelid margin. Angle of the needle is always medial, parallel to the skin. 0.6 units are given. Coming to lateral lower eyelid lines, it is midway between the first injection point and the lateral canthal line. So 1 centimeter inferior to the lower eyelid margin. Again, the angle of the needle inferior, it should be inferior and parallel to the skin. 0.6 units given subdermally. Points to be remembered are always give low volume with precise dosage. Avoid injections medial to the mid-pupillary line. Avoid in case if the patient has positive snap test, and avoid if the patient had past eye surgeries. Unwanted effects can be pseudoherniation or worsening of the under eye fat bags, usually seen in older patients with inelastic skin or if high doses are given. Then rounding of the lateral canthus can occur due to lateral injection too close to the lateral canthus. Then lagophthalmos, epiphora and dry eyes can occur due to injection to the medial to mid pupillary line. Then lip ptosis if the injections are too low due to diffusion into the lip elevators. So next, coming to eyebrow lift, we should know the difference between female and male eyebrow. In case of females, eyebrows are always seagull wing shaped, present over the superciliary arch, and the peak at the lateral limbus and slope till the lateral canthus. Tail is 1 to 2 millimeter higher to the medial brow. In case of males, it is lower, less arched, and more flat. So muscle targeted here are again the glabellar complex to elevate the medial eyebrow, and upper lateral fibers of the orbicularis oculi for the lateral lift, and frontalis to balance overall dynamics. So again, always given in the safety zone intramuscularly, superior lateral portion of the orbicularis oculi. So ask the patient to blink hard and hold, identify and palpate the muscle, and ask the patient to relax. First injection point is 1.5 centimeter lateral to the lateral limbal line. Within the safety zone, 2.5 units can be given. Needle is always angulated towards forehead. Then second injection point is 1 centimeter medial to first injection point, where 1.25 units can be given. For an arched brow, orbicularis oculi 2 to 3 points inferior to the eyebrow at the highest point should be given. Along with that, crow's feet has to be treated. Then medial frontalis 3 units in the mid part of the frontalis is preferred for overall balance. Points to be remembered here are not all patients have same degree of elevation. Patients with severe brotosis, there cannot be any improvement. Over treatment of the frontalis will always negate the results of the depressors. Unwanted effects can be lid ptosis. Injection too close to the supraorbital ridge at the lateral limbal line can cause this due to paralysis of the elevator palpebrae superioris. And asymmetrical eyebrow can also occur. So this picture shows overall summary of the injection points and the units to be given. So yellow dot tells that 0.5 units of injection to be given intradermally, white is 1 unit subcutaneous, blue is 2 units intramuscular, 3 is then orange is 3 units intramuscular, then red is 5 units intramuscular. This is also again a summary picture where the safety zones for each muscle area is given. Next, coming to muscles of the middle third of the face, the muscles mainly involved here are the nasalis muscle and the depressor septi. So nasalis is a horseshoe shaped muscle which has 2 parts, that is transverse part and the alar part. Transverse part mainly originates from the superolateral to incisive foramen of the maxilla, and the fibers extend superomedially forming aponeurosis. Insertion mainly over the dorsum of the nose, blending with the contralateral aponeurotic fibers, and it helps in drawing the nasal side walls upwards and medially and compresses the nostrils. So alar part mainly present over the nostril. It originates from the frontal process of the maxilla and gets inserted in the skin of the ala. It helps in movement of the nasal side walls outwards and downwards and helps in opening of the nostrils. Next is depressor septi. It is a small bilateral muscle, originates from the maxilla above the central incisor. Insertion is mainly over the nasal septal cartilage and it helps in pulling the nasal tip down. So nasal glabellar lines, also known as bunny lines or nasal scrunch, wrinkles on the lateral and the dorsal part of the nose. So it can extend from the lower eyelid till the cheeks. So it gets accentuated when there is squint forcibly, laugh, frown or buttocks on the upper face. Target muscle here is a nasalis. So it is again given in the safety zone. Needle should be inserted when the muscle is contracted, just medial to the nasion ala line, and the needle angle towards the nasal side walls. 1.25 units subdermally should be given. Points to be remembered are: do not inject too deep, do not go low along the lateral nasal wall, stay anterior and superior to the nasofacial sulcus and vascular area due to angular vessels. Unwanted effects can be lip ptosis due to lower injections, asymmetry and functional abnormality of the lips can also be seen. Then epiphora can occur due to higher and medial injections where medial fibers of the rectus are involved. So these are few variations where injection points can be given for the bunny lines. Then nasal tip ptosis. So there will be dip at the nasal tip, pulling up of the upper lip can be seen. So occurs due to contraction of the depressor septi. So injection technique is patient is asked to pull lips down. First injection is given into the columella and second injection just above the columella and the lip junction. Unwanted effects can be elongation of the lips, loss of definition of the philtrum, diffusion to lip elevators due to low injections, then piggy nose due to overcorrection of the dilator nares can occur. Next, coming to nasal flare. So due to repeated contraction of the lower nasalis, undesirable flare of the nostril can occur. 5 to 10 units bilaterally into the lower nasalis fibers over the lateral nasal ala can be given at the most active area of the muscle contraction. So now talking briefly about microbotox. Microbotox, also known as mesobotox or microdroplet, it is intradermal microdroplet of onabotulinum toxin type A. It relaxes fine lines and wrinkles and it has an advantage of no frozen or plastic appearance. Here 0.05 ml of the solution is injected at 1 centimeter intervals intradermally in a uniform grid-like fashion. So these are few injection points where mesobotox is given. The first picture shows over the cheeks and the lateral face, whereas the second picture shows over the forehead, and the blue dots are the traditional ones. So this was something brief about microbotox, which will be covered later on. These were my references. Thank you.
Thank you, Dr. Nikita. That was indeed a very exhaustive presentation of botulinum toxin with different indications in the upper face and mid face. We will have an extensive discussion on this a little later. Right now, it is time to go on to the next video, and that is by Dr. Adrija, who will speak on lower face indications of botulinum toxin, neck, and other areas. Please play Dr. Adrija's video.
A very good evening to everyone. I'm Dr. Adrija and I'll be carrying forward the discussion on botulinum toxin for the lower face, neck and the other areas. I'm immensely grateful to Dr. Venkat Mysore sir for giving me this opportunity today, and also to Dr. Rajat Kandari sir, the expert for today's presentation, for his invaluable guidance. Now I'll be presenting on these indications. First, starting with the gummy smile, it is the gingival exposure greater than 2 mm above the dental line while smiling and is formed due to the excessive contraction of the upper lip elevators. Depending on the principle, it can be of various types like anterior, posterior, mixed and asymmetric. The muscle targeted here is the levator labii superioris alicinasi, with the treatment goal being its partial inhibition. This muscle originates from the frontal process of the maxilla and inserts medially on the alar cartilage and the lateral head on the lateral part of the upper lip, causing flaring of the nostrils and the elevation of upper lip. Injection technique is we have to first identify the nasomaxillary groove with the index finger of the non-dominant hand and ask the patient to smile and check for the contraction of the muscle. Where the muscle thickness is felt at a maximum, a deep perpendicular injection has to be given 1 to 2 units per side. Complications can be in the form of lip asymmetry and upper lip ptosis due to diffusion into the lip elevators like the levator labii superioris or the zygomaticus major at the minor muscles. Sphincter incompetence can occur due to diffusion into the orbicularis oris muscle due to inaccurate injection or high volume injection. Flattening of nasolabial fold and relative lengthening of upper lip is also another complication. Next, coming to perioral rhytides. These are also called as lipstick lines or smoker lines and formed by the contraction of the perioral musculature, primarily the orbicularis oris, and is more obvious in individuals who purse their lips repeatedly, like smokers or those who play musical instruments with embouchure. It presents as wrinkles that extend radially from the upper and the lower lip border, and the lines can be assessed by asking to whistle, sip on a straw, or by asking the patient to pucker. The muscle targeted here is the orbicularis oris, which is a circular flat sphincteric muscle that encircles the mouth and originating from the modulus at the angle of the mouth and from the maxilla and the mandible above and below the lateral incisor respectively. It inserts directly into the lips, interdigitating with the fibers from the opposite side, thereby causing closure and forward protrusion of the mouth. The safety zones for the upper lip injection into the orbicularis oris are 1 centimeter lateral to 1 centimeter from the oral commissures and within the 0.5 centimeter or less from the vermilion border and the lateral and medially by the lateral edge of the philtral column. In the lower lip, the safety zone is 2 centimeter from the oral commissure and within 0.5 centimeter or less from the vermilion border. It is a painful procedure, so topical anesthesia 30 to 45 minutes before the procedure and ice pack just before injecting are recommended. Injection can be given as 4 points on the upper lip and 2 on the lower lip with 1 to 2 units at each side. Another recommendation is using initial 4-point injection with each point lying over the middle third of the lip on each side. Complications can be inadequate response due to conservative dosing, while overdosing can lead to loss of oral incompetence. Injecting too close to the oral commissure can lead to inversion of the upper lip and even drooling due to the lip elevators being affected. Asymmetrical smile, flattening of the cupid's bow, or asymmetry due to unequal number of units on other sides are other complications. Next, we come to the mellomental folds, which are also called as the marionette lines or the puppet lines, and is formed by the muscle depressor anguli oris, which presents clinically as a downturned mouth, giving the patient a resting sad look. The muscle can be assessed by asking the patient to pronounce the letter E in an exaggerated manner, or he or she can be asked to make a sad face. Now, the depressor anguli oris muscle originates from the oblique line of the mandible and inserts superficially into the modulus. Post-treatment, there is reduction of the dynamic marionette lines and the strength of the muscle is also reduced. The safety zone for injecting into the DAO is at least 1 centimeter anterior to the masseter border, posterior to the marionette line, and within 2 centimeter from the mandibular margin. Injection technique is usually a 2-point technique with single point per side. That single point is placed in the body of the mandible at the inferior most point of an imaginary vertical line that is drawn from the nasolabial sulcus, or it can be taken as the intersection of the lateral canthal line or the nasolabial fold. The dosage is given at 3 to 5 units per point, the total of 6 to 10 units of neurotoxin. Complications can again be sphincteric dysfunction if injected higher near the oral commissure or due to highly diluted toxin or diffusion into the orbicularis oris, or asymmetry of lips. Next, we take a look at the puckered chin or the dimpled chin, which is a wrinkling similar to the Porterange appearance and is formed due to the mentalis muscle contraction and presence due to the attachments and presence as dimpling or ridges and corrugations over the chin as the attachments of the smash to the mentalis become visible with the edge, with age. The muscle is assessed by everting the lower lip and pulling the chin up. Now, mentalis arises from the incisive fossa of the mandible and gets inserted into the skin of the medial chin, thus raising and protruding the lower lip. Post-treatment, there is smoothing of the chin and there is reduction of the dynamic mental crease as well. Che et al. Through cadaveric and ultrasonographic studies had delineated these types of mentalis, but their clinical relevance is unclear. The safety zone for injection into the mentalis lies lies at least 1 centimeter medial to the chin circumference and is within 2 centimeter from the mandibular margin. The injection technique can be of various types. The 2-point technique is recommended for those having a squarish chin or a vertical mental cleft, where 4 units is injected on either side of the midline into the 2 bellies of the muscle. Single point technique is for those with a pointed or a narrow chin, and 4 to 6 units of toxin is injected at the apex of the mental protuberance into the muscle. The diamond technique is injection of 2 units neurotoxin at 4 points in the shape of a diamond within the safety zone for the mentalis. Complications can again be sphincter incompetence and lip incompetence. Those with hypertrophic mentalis tend to develop an oral incompetence. So these patients are not to be treated with toxin. Next, we take a look at the botulinum toxin for mandibular contour. Now, mandibular contour plays an important role in the beauty and youthfulness of face. Repeated contraction of the depressor muscles of the lower third of the face and the neck lead to loss of contour in the jawline area. Botulinum toxin can reduce the masseter muscle mass and change the contour of the posterior mandible, and also recontour the jawline by negating the downward pull of platysma, which is known as the Nefertiti lift, as was proposed by Levy in 2007. We will see that a while later. So masseteric hypertrophy usually presents as a wide lower face that is considered too masculine for women. And those
there is a small mistake.
Jawline on the
presentation had to
those
come
having process in
Nikita.
headaches and teeth grinding
So
may
now what
also
we'll do is
it is clinically assessed by asking
Hello.
the patient to clench the teeth. Now, masseter is a thick quadrangular muscle of mastication and has 3 heads. The superficial head arises from the anterior half of the zygomatic arch and the malar eminence and inserts into the angle of the mandible. The intermediate head originates from the middle third of the zygomatic arch and inserts into the anterior half of the ascending ramus, the condyle, and the angle of the mandible, whereas the deep head, this arises from the infero-posterior aspect of the zygomatic arch and inserts into the posterior half of the ascending ramus. Now, this deep head is most important for us because this is where we will be injecting. So the safety zone for injection into the masseter is a zone whose anterior and posterior borders are formed by the borders of the muscle itself. The inferior border is demarcated by the mandible and the upper border is formed by a line joining the tragus to the corner of the mouth. Now, injection should be given a minimum of 1 centimeter within the borders of this zone. Injection technique, a 3-point technique is often used. It is usually confined to the lower quadrant of the muscle at the most bulging point. So 2 points 1.5 centimeter apart on an imaginary line just above the body of the mandible are taken as the base of the triangle. And the third point is 2.5 centimeter above this, forming the apex of the triangle. The dosage recommended is minimum of 20 to 25 units per masseter with a maximum of 60 units per masseter. Now, since the deep head is the place where the motor end plates are located, that is where we have to inject, and we have to use longer length 26 to 30 G needles to address this deep head. She et al. Had classified masseteric hypertrophy to tailor the botulinum toxin treatment, and they had classified it into 5 types. 1 being minimal and type 5 being excessive, that is having a massive single bulge. On ultrasonographic study, they found the thickness of masseter, and for less than 10 millimeter or mild hypertrophy, 20 to 25 units were recommended. For hypertrophy, for moderate hypertrophy with thickness 10 to 14 millimeters, 25 to 30 units of toxin was given. And for severe hypertrophy with more than 14 millimeter of masseteric thickness, 30 to 40 units per masseter were recommended. Complications can be in the form of difficulty in chewing or weakening of the pterygoid muscle if it is injected too high up. There can be a transient dull ache on chewing. Asymmetrical smile can occur if there is diffusion into the rhizorius or the levator anguli oris due to more anterior injection. Jowling of overlying skin can occur. This usually occurs because of overcorrection leading to fast atrophy of the muscle, causing sagging of the overlying skin. Scalloping of the lateral side of the face. Fasciculation can happen because of insufficient dosing. Bruising and hematoma are quite common, as is intrazygomatic hollowing. Now we will look at the platysma and the neck bands. Platysma is a broad flat sheet of muscle having two separate sheets which usually decussate in the middle and originates from the upper chest and inserts as 3 parts the medial fibers into the inferior border of the mandible, the intermediate fibers into the lateral half of the lower lip, and the lateral fibers into the modulus and skin of the lower part of the mouth. The variations, the anatomical variations are of 3 types. In type 1 is the most common, where there is medial fiber decussation 1 to 2 centimeter below the chin with separate muscle bellies in the suprahyoid area. Type 2 gives the best support in the neck region, where there is medial fiber decussation all the way to the thyroid cartilage, covering the submentum like a sling. And type 3 is worst for support, as there is no decussation and the 2 bellies insert directly into the chin as separate fibers. With aging, neck bands develop. Horizontal neck bands developed as the skin is pulled to the center, and hypertrophy of the platysma with separation of the decussated fibers cause vertical bands. So in the neck, skin laxity, platysmal neck bands, horizontal neck rhytides are the signs of aging that can be effectively countered with botulinum toxin. So let's take a look at the safety zone for the injection of these neck bands. It lies 2 centimeter inferior from the mandibular margin, 4 centimeter from the clavicle. The lateral limit is bounded by the oral commissure line, and the medial limit is 1 centimeter from the trachea. Injection technique: the muscle is assessed by asking the patient to clench the teeth and depress the oral commissure. The muscle ridge is palpable beneath the skin. One has to hold it with a non-dominant hand. The needle is angled medially at about 45 degrees to the neck and inserted. A slight increase in resistance can be felt as the needle moves from the skin into the muscle, and just there the toxin should be injected. For the vertical bands, address 1 band at a time. 3 to 5 points are marked about 1 to 2 centimeter apart, and a superficial intramuscular injection of 2 to 2.5 units per site is injected. For the horizontal bands, again, address 1 band at a time, and the lines that are visible between the anterior borders of the 2 sternocleidomastoid muscles are to be treated only. And multiple points are marked 1 to 2 centimeter apart. 1 to 2 units of toxin is deposited at each site. Next, we take a look at the Nefertiti lift. Nefertiti was an Egyptian queen whose jawline was remarkable in the field of history as well as in aesthetics. So the Nefertiti lift, as was devised by Levy, the aim was to redefine the jawline to reduce jowling by reducing jowling and improving the horizontal lines on the neck. Younger patients, those who have greater muscle strength and no significant laxity or submental lipodystrophy, are the ideal candidates for this particular injection. The patient is asked to pull down the platysma hard. Those patients where there is disappearance of the mandibular border indicates high possibility of success of this injection. Multiple sites along and under the inferior border of the mandible and the upper part of the posterior platysmal bands are marked, and 2 to 3 units are injected at each site, with a total of 15 to 20 units of neurotoxin per site. Tangential injections are preferred here rather than perpendicular injections because of easier spread of the toxin in the adjacent areas. Bruising, headache, muscle soreness, dysphagia, hoarseness of voice and neck muscles weakness due to overdose or diffusion into the sternocleidomastoid or strap muscles of neck are other complications that can be seen with this injection. Now, let's take a look at the microbotox therapy for the neck region. For the neck or the platysmal rejuvenation, grids are marked in the area to be injected. The area is 3 finger breadths above the mandibular border. The medial border is just posterior to the depressor anguli oris muscle, and the lateral border is the posterior border of the sternocleidomastoid muscle. 20 units of the standard dilution toxin is taken in a 1 ml syringe, and equal volume of lidocaine is taken, and 150 to 200 points are injected, raising blebs. Post-procedure, the area should have cold compression with ice gel packs, application of topical antibiotic creams, avoidance of massage, steam, sauna, sweat, dust, makeup, and exercise for 48 hours. Active movements of the injected area is encouraged. Now coming to the non-aesthetic indications of botulinum toxin. It is a safe and effective method for prevention of hypertrophic scar formation. Injecting into the orbicularis oris prior to cleft lip surgery has shown to decrease hypertrophic scarring. Chang et al. Reported narrower scars with better appearance, and toxin injection 2 weeks prior to scar revision surgery was found to be highly effective in the wound stabilization, wound healing, and prevention of wound widening during healing. Bay et al. Had reported intra-incisional injection of the toxin after thyroidectomy surgery in 20 patients. It was found to be associated with a significantly lower rate of post-op scar. Coming to body contouring, first let's take a look at the shoulder contouring. The muscle targeted here is trapezius. The dilution used is 2 units per 0.1 ml, and a total of 50 units of botulinum toxin is injected per site depending on the muscle volume. These are injected deeply into the superior part of the trapezius, and points are 10 to 12 points are marked about 2 centimeters apart. For cuff muscle contouring, the muscle bulge is mostly formed by the medial head of the muscle. The muscle is assessed by standing on tiptoes. The injection sites are marked 3 to 6 spots, 2 centimeters apart. And injection is given by 23 to 27 gauge needle, 23 to 27 gauge of 1 inch needle, and a total dose.
Yes, sir.
Hello.
Yes, sir.
Next, Dr. Rajat will speak.
Okay, sir. Okay, sir. So there is a 4-minute video remaining. We will play.
Okay.
Yeah.
Now is Dr. Adrija's over?
No, sir. 4-minute video is remaining. Yes.
Dose of 30 to 70 units is injected per site into the most prominent part of the medial head of the gastrocnemius with the muscle in a prone position. The effect starts in 1 to 2 weeks, peaks in 6 to 8 weeks, and lasts as long as 1 year. The complications can be in the form of weakness of the lower legs or swelling and pitting edema. In this picture, severe gastrocnemius hypertrophy was seen, and this is after treatment with botulinum toxin 200 units in each muscle. Hyperhidrosis is the next topic, which is a production of excessive sweat beyond the amount required to return the elevated body temperature to normal. Botulinum toxins are widely used as the second-line treatment where topical treatment strategies have failed. Before injection, the starch iodine test can be performed to document the extent of excessive sweating and to determine the number of injection sites and the quantity of toxin needed. For the iodine starch test, hyperhidrotic area is first completely dried and iodine solution is applied using a swab. Powdered starch is sprinkled over the solution. Then the patient is meant to sweat by an external source. Whereby the sweat turns starch black, delineating the affected area. For axillary hyperhidrosis, anesthesia is not necessary as it is almost painless. Dilution can be in 2 forms, diluting 100 units with 5 ml of normal saline, yielding 2 units per 0.1 ml. Or it can be diluted with 10 ml of normal saline, yielding 1 unit for every 0.1 ml. The advantages of low dose high volume technique is fewer injections, less painful and lower cost, and reduced risk of neutralizing antibody and immunoresistance. The injection points are marked, some 10 to 20 points are marked at a distance of 1.5 centimeter. Over the hair-bearing area of the axilla, and tiny intradermal wheels are raised starting from the periphery, circling into the center. A dose of 2 units at each site, total of around 50 units per site. The effect begins in 2 to 4 days and peaks after 1 week and lasts up to 4 to 10 months. Pain, edema, ecchymosis, bruise, purpura, short-term hyperesthesia are some of the side effects encountered. Coming to palmoplantar hyperhidrosis, the injections of botulinum toxin here are very painful due to the thicker and tougher skin of the palms and soles. Anesthesia topical in the form of topical amla is not quite successful as it is only limited to the skin surface. Vibration anesthesia somehow makes the injection more tolerable. Nerve blocks in the form of median and ulnar nerves for the hands and posterior tibial and sural nerve for the feet have been tried with more success. The injection procedure, the dilution used here is 100 units diluted with 5 ml NS, yielding yielding 2 units per 0.1 ml. And the injection site are 35 to 40 injection points for each palm and 62 injection points for each sole, 1 to 1.5 centimeter apart, depending upon the area of the hyperhidrosis. Dosage is quite large and the range of dosage is quite large, 50 to 165 units per palm, and the dosage exceeds the doses for the sole exceeds that of the palm. The duration of the effect is some 3 months to 12 months. Complications can be in the form of pain during injection, vasovagal attacks due to the pain, wrist pain, cramps, hematomas, and also transitory weakness of small muscles, which can last for 2 to 8 weeks. Now, these are some of the very uncommon indications where botulinum toxin has been reported to be of success. These are post-acne scars, post-herpetic neuralgia, occipital neuralgia after hair transplant, androgenetic alopecia, hidradenitis suppurativa, Raynaud's phenomenon, chronic anal fissure, vulvodynia and vestibulodynia, and also has found its use in chronic migraine. Now, these are my references. Thank you.
Thank you. Thank you, Dr. Adrija, for that nice discussion of the lower face and other indications. I now request Dr. Rajat Kandari to show his presentation as well as video. As I introduced earlier, Dr. Rajat is a very well-known expert in the field of aesthetics, particularly botulinum toxin, and we are very happy to have him on our lecture. Over to Dr. Rajat Kandari.
Thank you, sir, and thank you for having me again for this wonderful meet and initiative. Just go to. Thank you to all the people who've spoken, and thank you, Adrija, for talking about the lower face. So you've covered quite a bit. I'll be covering some things or the practical aspects, and try to take some of the numerous questions which have been there on the chat box as well, at least the ones which are pertinent to my talk. So when we talk about botulinum toxin, first and foremost, we are talking a bit about balance. And if you see me in the first video now, here I'm smiling and I'm everting my lower lip. So when I'm smiling, there are elevators moving, and when I'm everting, I might look funny, but that's where my depressors are moving. And along with the depressors of the lower face, another depressor which does a lot in the lower face is the platysma muscle. And it is all a balance of the elevators and depressors, so to say. And you can see that there are two slings on the face. One is the brow and one is the lip. So there are elevators, which is the zygomaticus major, the LL san, the LLS, zygomaticus minor, and the LAO. And then there are depressors, which is the DAO, DLI, and the platysma. So when we're injecting, we need to maintain this balance and basically slightly knock off the depressors so that the person looks more pleasant. Now, other than the depressors of the lower face, there is also one more muscle, which is the masseter muscle, which was talked about, and that is a muscle of mastication of the lower face, which I'll be coming to as we go on. Now, when you look at this photograph, this is a perfect patient for injecting in the lower face. Why I say that is because whenever someone asks me, or whenever you need to inject the lower face, it is pertinent that you actually can identify a hyperkinetic muscle and ideally palpate the muscle as well. If you cannot see it or cannot feel it, my suggestion would be try not to inject into a muscle of the lower face, because it's a compact spatial arrangement and you might end up with some untoward outcomes. In majority of the individuals, the DAO lies approximately 1 to 2 millimeter anterior to the masseter, and this is an easy way of identifying the muscles by telling the patient to evert the lower lip or say E in an exaggerated manner for the platysma. Now, before we go into how to inject the DAO, which has been talked about a bit, we must know about something called the modiolus. The modiolus is a bead-like arrangement in the lower face wherein the muscles of the lower face converge. And this is situated 10 to 20 meter lateral to the mouth corner. And it has different locations, as you can see in this illustration out here. But what is highlighted in the red says that modiolus is located below the level of the interchelion line in about 60% of Asians, which means that there are many books which will tell us that just go about a centimeter or two below the interchelion line and inject the DAO. But when we're injecting in Indians, it's ideal to stay even further below where the muscle is the broadest, as you can see in this photograph. And you see that the muscle here is superficial. Below the DAO lies the DLI. So when you're injecting this muscle, it's a good idea to be superficial and have your needle pointing away from the medial line and no vigorous massage. As was already said, it's easy to identify it. Ask the person to evert the lower lip, and here you draw an imaginary line from the nasal ala onto the mandibular border. Just medial to that line is where you want to inject the muscle. So this is an illustration, which is a photograph of a patient which shows you the DAO in motion, and this is how you're injecting. I ask the patient to evert, superficial injection, needle pointing away from the medial border, away from the DLI, and that's 2 units. And on the other side, again, I'm seeing the DAO, I've marked it in line with the nasolabial, and again, I inject 2 units into the muscle. At times, when you end up hitting the DLI, this was a patient wherein I injected the DAO pointing inside, and that was my learning. And I ended up hitting the DLI, as you can see. And this results in an asymmetric smile. This photograph on your WhatsApp will flash about 7 to 10 days after you have done the injection. It's a slight challenge to correct this, and obviously very, very frustrating for the patient and embarrassing for you as well. When we come to the mentalis, inject below the mental crease. As Dr. Adrija said, there are different points and ways of injection, which we had illustrated in Dr. Venkatram sir's book, the ACSI textbook. But if you want to keep it very, very simple, a 2-point injection technique with 2 points with your needle pointing inside towards the midline, not outside, because again, you will be ending up hitting the DLI and injecting the muscle. The origin is the canine fossa, incisive fossa, but it eventually inserts into the skin, which is giving the puckering. So 2 to 4 units either side with needle pointing towards the midline. High volume injections or improper technique. That means if you go too high, you will hit the orbicularis oris muscle, and if you go too lateral, you will hit the DLI. So this can result in motor dysfunction of the lower lip, sphincter incompetence. Most commonly, if you do too high a volume, your patient might come back and say that the food or fluid is getting stuck between his lip and the gums or pooling there. That means they are unable to approximate the lip to the gum margin. This is how you inject. Again, I've marked the 2 bellies. Simple injection, needle hub. Someone asked, how do we assess the depth? So for assessing the depth, you should know the depth of your muscle, where the muscle is originating, where the muscle is inserting. Where it's inserting but if it's bulky, you go full needle depth. If it's inserting into the skin and it's superficial, you go 1/3 needle depth. But if you're going into the bulk of the muscle, you go full needle depth. This was already covered, the 3 heads of the masseter. I won't go into this again. But a few practical tips again. So a minimal dosing of the masseter can be around 20 units to start with. You can go up to 40 to 50, but that's rarely the case. Dosing should be restricted to less than 60 units to avoid inadvertent diffusion. In my many years of practice of injecting the masseter, I would have done 60 units barely ever. But yes, up to 40 units, yes. The most prominent, again, a question was there that should we inject only in the safe zone, which is the posterior inferior quadrant. Now, there are reasons for injecting into the posterior inferior quadrant, which I'm coming to. But yes, if at times your muscle is very, very bulky, you may go out of this safety zone as long as you know that you are in the bulk of the muscle. Then the chances of going wrong are minimal. Why is going into not the posterior inferior quadrant and shallower and more anterior a problem? If you see this cadaveric dissection, you can see that this muscle, this is known as the rhizorius, it's attaching superficially onto the masseter and into the anterior border of the masseter. So if you inject too anteriorly, you might hit this muscle. Secondly, this lower picture which you see is from Kim's anatomy, wherein there is a black line from the interchelion or the corner of the mouth to the ear lobule. And Kim's anatomy says that you stay inferior to this line. I would suggest that you stay inferior to the mental crease for extreme safety. Of course, if it's again a very bulky muscle, you may go above that. This is the rhizorius again. So this is where it is attaching, and this is what you want to avoid hitting. Because if you do hit it, this is what will again be sent to you on your WhatsApp 10 days after the masseter injection. And this results in a crooked smile. That means you hit the rhizorius and the patient is having a slightly crooked smile. Another important tip for the masseter is using long needles, not the standard insulin 31 gauge needle, because it has 3 heads. So you don't want to miss the deep head, because if you do, you will give no effect to your patient, as you can see in this photograph. This was one of my first patients of masseter injection. But if you do use a longer needle for a bulky masseter, you can give beautiful outcomes as well. Along with the masseter, there is a globular swelling behind it at times, which is the parotid gland, as you can see in this individual. It's very simple to go into the parotid and inject it as well. I'll just come to how you do that. This is the masseter injection, not the best video, but it'll give you an idea. I'm in the lower posterior inferior quadrant and I'm injecting in a triangular manner. And you can see I'm using a longer needle. Now, when you do not use a long needle, at times, this is what will happen about 10-15 days later. You will ask the patient to clench the teeth and a deep head of the masseter bulges out. So when this used to happen, we started using longer needles for injecting the masseter. But when you use longer needles, at times you miss the superficial head, which is paradoxical bulging of the superficial head. Now, how do you differentiate between the two? In a deep head, it'll feel hard and it'll pop out as soon as the patient clenches. In case of a superficial head, it'll be soft and flabby. Now, why is the superficial head missed? Because when you go too deep and hit the deep head, in some individuals, there is something known as the deep inferior tendon, which prevents the diffusion of your toxin from the deep head to the superficial head. So there are certain authorities who have recommended a bi-level injection. That means you go deep, withdraw, and inject again a little bit, or you use 2 different needle sizes. For the parotid, you go straight into the parotid, just like this. 5 points, you can do about 4 to 5 units each point. This was a photograph sent to me by a colleague. If anyone would like to guess what happened here, we're on a Zoom meeting, so I can't really have interaction like this. But what has happened here is that the DAO was injected and the masseter was injected. But unfortunately, the DAO has also gone wrong. That means the DLI is hit and the rhizorius has also been hit while the masseter is being injected. So please be very careful. Like I said, if you don't see it and don't feel it in the lower face, don't inject it. Again, there was a question, two questions. One, DAO, should we inject with the LL-SAN? Since we're starting the LL-SAN, no, DAO can be injected with the LL-SAN, of course, to balance things out. But typically, the LL-SAN muscle is injected with the depressor septi, because when certain patients smile, they have a drop in the tip of the nose. So doing both of them together is wise. With the DAO, you may combine, of course, your platysma, because it will give a good action. Now, for the gummy smile, it is defined as gingival exposure greater than 2 mm above the dental line when smiling. And this has been already discussed. But again, there was a question which was grading for gummy smile. Now, gummy smiles might be of different varieties, ranging from just a canine smile or a full width smile. Now, this is called the Yonzai point. First, we go to the straight gummy smile. This is the standard injection point just next to the nasal ala. You ask the individual to do this. You can ask the patient to smile and feel for the contraction of the LL-SAN. There are some individuals who can do what you're seeing in the picture on the right. I am not able to contract voluntarily my LL-SAN. So if you see it there, you inject directly deep down into that area, about 1 to 2 units. However, if it's a much wider smile, you may want to go 1 centimeter off that area, lateral to it, and inject so as to diffuse into the other muscles as well. While you're injecting this, please make sure that you don't overdo this, because it may lead to a lip drop and flattening of the nasolabial fold completely, which is not wrong for most individuals, but you may lead to a completely drop in the lip to some extent. And also you need to balance the DAO as was asked. So if the DAO is very, very aggressive, then you may want to balance it out. Coming to the orbicularis oris muscle, this has 2 parts. One is the pars peripheralis and one is the pars marginalis. Now, when you're inject this muscle is a sphincteric muscle, and you can see it's surrounded by various muscles all around it. So when you're injecting this muscle, you need to be a little conservative, and I would suggest start doing this when you're a little well versed with your injection technique. This is how you ask the patient to elicit the action of the orbicularis oris. Injections into this area, inject into the area of maximal contraction. Dr. Adrija said something about not being in the center. Why she said that was that if you go into the center, you will be inhibiting a lot of the action of the orbicularis oris. Plus B, it will completely flatten your philtrum, so which does not look natural. So injections are 1 to 2 units into the pars peripheralis of the upper and lower lips intradermally, and symmetrically as well, because sometimes it leads to a little asymmetry. You can see I asked the patient to do a kissing motion, identify. This patient wanted a lip flip, which is why I'm doing this. She didn't have a very hypertrophic orbicularis oris. So it's the same way it's done. And you inject, you load only very little, so that sometimes you've got a sticky syringe, so you don't end up injecting too much more. So that's 0.5 to 1, and then again a little more, just a small little bleb, and so on, right, on the other side as well. So superficial fibers are treated by raising a wheel at the junction between the peripheralis and the marginalis. So injections may prolong the effect of lip fillers, which is why it's also good. The total dose, which has been mentioned in some studies into the upper lip, should not exceed 8 units. I have never done that much. And for the lower lip, should never exceed 6 units. This is just one data. I would suggest I typically don't go above 2 to 3 units in one session. Again, this is a little asymmetry you can see, which is missed on one side. Coming to the platysma is a muscle which is a depressor of the lower face, but we often forget the lower face. So one of the main depressors of the lower face is the large platysma muscle. And how does it work? It depresses the whole lower face down with its pull, right? And it has three main components. It's got the platysma pars mandibularis, which you see out here in the blue. This attaches to the base of the mandible. We've got in the red the platysma pars labialis, and it attaches to the lower lip, and along with the other depressors causes a pull on the lower lip and the face. And we've got the platysma pars modiolaris, which attaches to the modiolus. Now, treating all these fibers in a successful manner, along with the other depressors of the face, gives the patient a nice mini neck lift feel, and it also causes a better cervicomegaly. So basically, it means that you have three parts of the platysma, and typically you're treating the platysma pars mandibularis. And there was a question which says that when we're doing a Nefertiti lift, why is it said that a blunted mandibular border is a good candidate? That is because the platysma is having too much of an action there. So if you knock out those fibers of the platysma pars mandibularis, you will get a more defined jawline. So Dr. Adrija talked about the technique. I'm showing the technique out here. Straight into the band, hold the band with your non-dominant hand, ask the patient to say E and inject into the band. 3 to 4 units or 2 to 4 units, depending on where you are. So I'm injecting 2 to 3 units at each point, 1.5 centimeter apart. An important point here is please mark out your sternocleidomastoid before doing this. There, she said E again, and I can identify the bands and I inject into the bands. This is the points of the Nefertiti lift. You ask the patient to say E again, identify a lateral platysmal band, which is along the mandibular border. You inject that. Superficial blebs in a triangular manner to give a more effective and better cervicomental angle. Microtoxin, I'm quickly going to run through the last couple of slides. Microtoxin, the simplest way to do microtoxin, I would say, is use a standard dilution and adjust the dose according to the area that you are treating. And this is how you can practice on your table. You can, this is a 0.1 ml drop, 0.05 ml drop, multiple small droplets of 0.05 and much smaller droplets. This is how you do it. Superficial blebs. Ideally a Luer-Lock syringe, but sometimes challenging to get with a 40 unit marking in India. You always get them with a 100 unit marking. And this is how you go ahead. Superficial uniform micro droplets in the superficial muscle fibers so that they don't go deep down into the deeper muscle fibers. But what I meant was using a standard dilution is that you use 2.5 ml of normal saline and dilute it further according to the area that you're treating. For example, if you're treating the neck and jawline, you fill it up to 24 units and the rest of the syringe you fill up with normal saline or local anesthetic, and thereby for other areas. And someone had asked again in the chat box that who's the right candidate? Where should micro-Botox be done in the neck? If you've got crepey skin along with bands, you can do both. If you've just got crepey skin, I would maybe do microtoxin with something like Profilo. And if you've just got bands with elastic skin, just go for the bands. Of course, you can use energy-based devices as well. Coming to axillary hyperhidrosis, again, different dilution techniques were mentioned by Adrija. But I would say, again, I use a standard dilution to not confuse things. It's a very easy, effective, and highly satisfying technique. 2 centimeters to 2.5 centimeter apart. I usually do 50 units each side for a severe, moderate to severe case, by 25 points on each side. For the palms, it's a little more challenging vis-a-vis the pain. You may ask your assistant to hold a vibrator as well as some ice and inject 1 to 2 units each point. Again, your dose might vary according to the hand size as well. Patient may face a little muscle weakness for some time. And yes, topical anesthetic can be used for axillary hyperhidrosis as well as palmoplantar hyperhidrosis. Again, for hypertrophic scars and keloids, some data which says that it can help alone. This is a case wherein I've used it along with triamcinolone acetonide and with reasonably good outcomes. Again, similar with single session of fractional CO2 and transdermal triamcinolone, and around the borders, abobotulinum toxin intralesional and microdroplet around the borders. I'm going to skip this. In HS, again, we have used it and it does help to some effect, but of course not alone as monotherapy. There is some data that it does help and decreases apocrine sweat production. Dr. Venkat sir had asked me last time about PHN, I remember, so I have included that slide this time. This blocks the release of substance P, calcitonin gene-related peptide, and you can mark the area of neuralgia and multiple points 2 to 3 centimeter apart, and you can see the repeat this if required as well. Some evidence in androgenetic alopecia. Due to constraint of time, I'm going to skip this. Thank you very much.
Thank you, Rajat. That was a very nice talk on the different uses of botulinum toxin other than cosmetic also. Thank you so much. Now we have Dr. Rasia's presentation. Dr. Rasia, I think she has a video to start with, and then she will have a tips lecture on how to establish a successful botulinum toxin practice. Over to Dr.
Thank you.
Rasia.
Thank you, sir, for having me. As always, whenever I'm invited to your series, I start learning more than teaching, I feel. Thank you for this opportunity. I think you can see my screen now. Are you able to see my screen?
Yes, ma'am. Yes.
Yes, okay. So we'll start with the video of the upper face. I think, thank you, Dr. Nikita, for doing that beautiful presentation on the upper face. And we'll start with the video here. I think, so we can see that when we are analyzing the upper face, we are looking at the muscles which cause the frowning, which are the 3 muscles which are the eyebrow depressors. The first is the procerus. The procerus is a pyramidal shaped muscle which is taking its origin from the nasal bone, inserting in between the eyebrows and causing that horizontal wrinkle that you can see on our patient's face. The next muscle is the corrugator. These 2 muscles, this is a 3-dimensional muscle. It is originating deep on the supraorbital rim and inserting, going more superficially into the skin just above the eyebrows. So when you mark the procerus, you're connecting the line between the medial end of the eyebrow to the medial canthus on the opposite side, and you're taking the center point of that. And for the corrugator, you're marking the first point, which is going to be above the mid-pupillary line, and the second point is going to be medial to the mid-pupillary line. So somebody asked, what is the lateral most point that you can quote with the corrugator? It is medial to the mid-pupillary line. So the no-go zone is above the mid-pupillary line. You mark it. Then you come to the next muscle, which is the frontalis, the only brow elevator, as Dr. Nikita put it. You have to treat this muscle with a lot of respect because it's the only one which is going to give you the elevation. So when we look at the frontalis, this patient has a completely complete frontalis, which was the type of frontalis Dr. Nikita mentioned about. So you take the marking above the lowest line of the forehead lines, vertical wrinkles, or 2 centimeters above the supraorbital rim. And then you are going to make your marking in an M or a zigzag shape pattern. In a man, you want to give a softening of the eyebrow lines. You don't want to give them a frozen appearance. Actually, even in a woman, you don't want to give them a frozen appearance. The fourth muscle in the upper face is the orbicularis oculi. You can see that the orbicularis oculi is causing the crow's feet, one of the first signs of aging. And you are going to take your marking 1 centimeter lateral to the lateral orbital rim, and you are going to take a C-shaped second and third marking, so that you are going to cover the whole section of the orbicularis oculi. You can also see, you take another marking, but make sure that you do the snap test. When you do the snap test, if the skin is returning very slowly back, you are going to avoid doing the injection there. So when it comes to the injection of the procedures, you saw that the non-dominant hand was making sure the muscle was being kept intact, and then the injection of the corrugator is going to be in 2 different depths. Again, you can see that I'm injecting a very more superficially in the second point, because the muscle corrugator becomes more superficial as it inserts into the lateral part of the eye. The last injection is the orbicularis oculi, the C-shaped markings. You can see again, as Dr. Nikita pointed out in her presentation, we want to make sure that we are going to give microtoxin in the infraorbital area. So here we are injecting 4 units in the upper part of the eyelids, but when we are injecting the lowest point in the infraorbital area, we are actually going to use a microtoxin to prevent, because we saw the snap test was slightly positive in this patient. So now I will go on to my panel discussion. So the panel discussion was about I'm going to invite Dr. Rajat Kandari and Dr. Aniket Venkatram and Dr. Venkatram Mysore to also join me on this panel. But before that, I wanted to have this one about why you should all start toxin in your practice. We all know that botulinum toxin is the most common non-surgical facial anti-aging treatment being offered worldwide. It's got an easy learning curve. It's low on investment. You don't have to buy a big laser machine or a radio frequency machine to get the results. And you have recurrent returns. That means once you've got a patient with who does toxin, they love the results, they keep coming back to your clinic. So, and it brings more aesthetic practice patients back into your clinic. Some injection tips, and I think the most important injection tip for a patient with a botulinum toxin is that don't lose that patient. It's the goose that lays the golden eggs. You want the goose to come back and lay the golden eggs in your clinic every 6 months, every 4 months. I think Dr. Rajat will agree that you want to keep this patient, your patient, and happy with you always. And these are the first 2 things that what Dr. Arthur Swift, he is like the guru of toxin as well as fillers. He says, if you bruise them, you lose them. So all the patients who are coming for aesthetic treatments, they are coming to look better. So they want to be treated well. So you don't want to bruise them. You know that sticking a needle into a patient's face will cause a chance of bruise is always there, but try to minimize it by using thinner needles, by making sure that you're using a lot of ice, just like Dr. Rajat was doing when he was doing the injections on the neck. And if you pain them, if you don't pain them, you keep gaining them, so that this procedure is slightly painful. The toxin itself is painful. Though we use really thin needles, it is quite painful. So you make sure that you give a lot of give a lot of toxesthesia and anesthesia, whether it is in the axillary area. You can help them to be more comfortable so that they stay in your practice. During the consultation, listen more, talk less, and understand more what the patient is really wanting from the aesthetic treatment. And the post-treatment care and follow-up is extremely important to having a successful practice. And I saw Dr. Rajat mention twice in his presentation saying that you will get a WhatsApp photograph after 10 days. That means that you are accessible to the patient. But it's not his personal phone. I'm assuming it is going to be his staff's phone, and that they are doing a follow-up post-treatment proactively sometimes, and even sometimes the patient doesn't want to come back to you for the complication, but so you should proactively call and make sure that the patient is doing fine. A consent form and pre and post video treatments, especially for toxin, because in toxin there is a lot of movement involved, and you may not see the change in the side effect the patient is having on a photograph. You may need to see it on a videograph. So I think this is something that I would say. How to start a successful toxin practice. So Dr. Venkat's topic was successful. I took out the successful from there because I asked him, how do you define success? And I will say, sir, I define success because you called me for this talk. So I'm successful. So you have recognized me and you have called me to be in this talk. So I am going to say I'm successful. I think Dr. Rajat will also agree with this definition. But I will start by saying what the eyes cannot see what the mind does not know. So when we start looking at the lower half of the face, which is a very interesting photograph you put up, Dr. Rajat, over there. Say the lower half of the face is pulling down the upper half of the face and it's blunting the jawline. So if you do not understand what are the muscles which are doing that and how we can treat it, then you will not see botulinum toxin as one of the effective treatments. So the first thing I feel that you have to understand in toxin treatment is learn. And there's a lot of things to be learned, and if there are a lot of lectures, so every time please keep learning, listening, because then you will start seeing these things. But then I'll come to the first question, Dr. Rajat, training. Where do people get trained for botulinum toxin for?
I think, Dr. Asya, when we started our practices, the avenues were very less, but now there are numerous avenues. We are right now in a training program. There are numerous hands-on training, and I think with lovely seniors like you out there, they can contact you or any of us.
Yeah,
and I think
I know.
all of us are fairly accessible to give them training. There are so many workshops. I think what's more important is that after the training, try and do the procedure. That's what important. I think all of them now know too much. So sometimes I feel there is a inertia to start things and they keep thinking what will go wrong, what will go wrong. But I think they need to start because there's no better learning than actually doing and getting your hands dirty.
May I say something here, Rasya?
Yes, sir, please, sir.
See, as you rightly said right in the beginning itself, this is not a very difficult technique to master. It is not that it will take a long time to learn. It's not like hair transplantation wherein you will do 100 cases before you can do something properly. But I think here the issue is that one is of the attitude. Second is that they have to have the skill to talk to the patient and convince them. That is where I think more skill is needed than to give the injection itself. So one is, of course, they should be convinced that I am going to achieve something very good. That attitude they should have that confidence. If they don't have the confidence, then they will not be able to inject. Second is that the way they speak, the way they communicate should be ultimately to be able to convince the patient so that the patient is willing to get injected. I think this is where what Rajat said that they should start injecting comes in. So probably the lack of the second one particularly. So I think they have to observe people how somebody convinces a patient for botulinum toxin, not just observe how to give the injection.
Okay. So do you think that because we talk so much about complications, Dr. Rajat, even in your presentation and all the presentations which preceded yours, is it deterring them from starting doing the injections when they go into their practice? Do you think that we should talk less about complications because the quacks seem to be doing a very good job of doing the toxin and doing the convincing of the toxin because probably they're not aware of the complications?
But that's the difference between them and us, right? So we need to talk about it and be aware about it, I think. And But yes, there is a little bit of, I also try and teach every month someone or the other, but there is this slight fear, but I think you need to overcome it. And like Sir said, it's not rocket science, but what I think improves over time is your outcome, how your outcome is. When you start, you might be hitting the frontalis when you're doing the glabella, but when you start you only learn by doing it that this is what went wrong, and I can maybe make this even better in the next go. While there's subtle improvements, I think the outcome becomes better. And like you said, that patient comes back for that outcome. So if they are comfortable and it's a beautiful outcome, they'll come back to you. The precision in injectables is all that is important. So 1 point here or here will make all the difference.
Yeah, and the best part is, even though if at all there is a bad side, there is a side effect, it tends to go away. And
In most cases, yeah.
in most cases. And the second thing is, because most of the time the side effect is from a diffusion effect. You've not actually accidentally hit the muscle on purpose. It diffuses earlier, or it disappears faster than the botulinum toxin result would go away. For example, even if you had an eyelid ptosis, it would disappear in 4 to 6 weeks, whereas the botulinum result itself would last 3 to 4 months. So I think
Sorry, I think I showed in my presentation, I think I have had all these complications.
Yes.
So I think everyone has it. So if you're not having it, you're not learning. So, but the main thing is you learn from that complication and try not to repeat it.
Yeah. So it is like getting
all complications in dermatology. There is nothing very serious. I mean, except maybe if somebody is really careless or has a really poor luck in injecting into a vessel in a filler which lands in the eye. I do not know if it has ever happened with a dermatologist. But that, except such things, where is a serious side effect in anything that is done by a dermatologist?
Sir, injection into the vessel is not uncommon nowadays, and which is why I think it's important that we should know how to deal with it. Because if you don't know how to deal with it, then you will get into that serious domain.
Yeah. So I think what we're trying to say, it's like getting onto a cycle and starting cycling. The only way you will be successful is if you keep cycling. If you don't even get onto the cycle and start cycling, you cannot expect to be a successful cyclist. So I think a lot of people who come to me for training, and I think it's not just paid trainings. SIG did a series of free trainings last year. I was part of it. Dr. Rajat was in the SIG aesthetics, and they have put out beautiful, there's a lot of literature available about botulinum toxin, videos available online about botulinum toxin. So I think there's no dearth of training, like we are all trying to tell you, but the idea is to start talking. And please start injecting your family, your parents, your in-laws, your husband or your spouse, your staff. They are willing people, and once they know and they have been injected, they will be confident to tell once your staff, especially your staff, if you inject them and they like the results, they are going to be your biggest heroes in convincing patients to have the procedure. There was a question here about the type of toxin and which type of toxin you would choose in your practice. Dr. Rajat, do you want to take this question?
So what is the exact question?
The question is, how do you choose a toxin? Is it based on indication, or is it the comfort of the injector, or is it, for particular indication, you have to choose one particular toxin?
So I think there's subtle differences in the science, but typically all of them are doing similar things. At least botulinum toxin type A is what we have in India. And I have, after using everything, found one particular toxin better than other because it gives me faster outcomes as well as more longevity in my practice. But I think it varies from person to person and their comfort level. But I don't think there's a protocol that for an X indication you use an A toxin. So I think you can choose what works for you.
Yeah, I think I agree with Dr. Rajat. Sometimes some of the toxins are available as 50 units vials, and some of them as 100 or 300 or 150 vials. So if you think that you will not get a patient within the next 1 month and you don't want to open a 100-unit vial, you might want to use the company which offers you a 50-unit vial. So that is the only reason you would make a change if you were a beginner versus one of us. I feel that toxin doesn't differ and does not differentiate.
One question here.
Yes, sir.
Now, there are some toxins which are being manufactured now in India, and they have also been introduced. Any opinion on that?
Rajat, will you go first?
So I've used them, and again, nothing wrong with them. I think comparative data will tell us which, if there's a better or not. There's already some which is there, and there is some which is in the pipeline, wherein comparison for each indication is being done with a different toxin vis-a-vis the Indian toxin, the Indian botulinum toxin. So I think time will tell which one outperforms or doesn't, or if there is any significant difference. But typically, it works decently well.
And it is slightly cheaper, so that
Yes.
may be a consideration for some people.
Yeah, and I think Dr. Chandrasekhar et al. Have published a paper
Yeah,
with they looked at periorbital wrinkles, sir. It is published in Journal of Aesthetic and Cutaneous this one. So surgery. So we can definitely, you can look it up and you will know which toxins I'm talking about. But it showed that the Indian toxin did as well as the original molecule. The original molecule being Allergan's molecule. My slides are not moving. I don't know why.
So till that is sorted out, we can take some questions in the chat.
Yeah. So which indications are good to start with, and which are the more complicated indications that you would probably want them to wait on before they started injecting the patient? Does this make a difference? Because you don't want to end up with complications in your initial patient, so that you would be more comfortable to keep on injecting.
I think with botulinum toxin, most patients come in essentially for the upper face because that's what they know that the Botox is correcting. I mean, the ones who are well versed with it. And then you can tell them that, a broad face or a downturned corner of the mouth or the neck are good indications. When first I would start with the upper face, surely.
Yeah.
Because it's simpler, or so probably the easiest would be crow's feet.
Yeah. And how to start injecting?
Jump in there.
I think so.
Read and be sure you know what you're doing and start injecting. And I think there were times early on in my practice wherein, patients made me read because there were times when I used to do particular indication and then they wanted yet another indication.
Yeah.
So that made me read and I used to go back, but be honest with them that I think give me some time to come back to you, because if you don't know and you're injecting, that's not right, because again, you won't know where and what you're doing and how to handle if something goes wrong.
Yeah. So I think all of us will start doing procedures for the first time at some time. And we showed that these are intramuscular injections, but it is or intradermal injections. These are not something that you have not done before. It just is particularly understanding the anatomy of that particular muscle and injecting. And once you know that, you will become good injectors. And I think all of us have had the same learning curve. Like I've had people who came and said, I want to do the Botox lip flip. And I was like, what's that? This was a couple of years ago. And then they showed me the videos, and then you learn how to do it. And then you try to replicate the results and explain to the patients, and definitely start injecting. If you don't start injecting after learning, I think then you miss an opportunity. You will not be, then you go on to the next workshop and then you learn, then you come back and don't inject again. You're just going and attending workshops.
I think that is a very important point, because this is something which I have seen quite closely, because we have fellows. Now, one of the things which I have observed in Botox practice is the patients are not amenable always to be injected by somebody else unless it is a workshop and you are giving it free. So if they come to Russia's clinic and want Russia to inject, it will have to be Russia only. It's not like a laser that a technician will do in place of the main doctor. So this is not something like that. So my advice to fellows is that when you are doing something else like melasma or something, if they have something, then you talk to them, and you talk to them one visit, and second or third visit they may agree. So that is where that confidence to inject also will come in. So that is why I told right in the beginning that the confidence has to come from within the mind, and that confidence has to show in the way they speak. So if you're nervous while talking about injection, so you'll be nervous while injecting also. So I think that is where it should start.
So how to promote botulinum toxin to our patient? I think, Rajat, this is a very important question I wanted to ask you. Your father has had like a general dermatology practice for all these years, and then you have built like a fantastic aesthetic practice where he had a dermatology practice. How did that change? How did you change it?
I think when I came in, a lot of the patients didn't even know we had a laser. But I think just as Sir said, that, keep talking to them, keep making them aware that this is happening. I used to have even my front desk keep telling them that this does happen here now, and feel free to connect with us in case you would like. I've never really pushed things, but yes, awareness is important. And as Sir said, that you need to talk to your patient a bit. And make them aware that this happens here, and we are happy to do it. And of course, I think now social media is there, so at least create an awareness that you do offer these services, and if you're talking somewhere about it, you are, I mean, at least that much as a doctor you can do.
Yeah. So I think that putting out the displays in the reception area about the procedure.
Oh, yes, I did that as well on the screen. Yes.
Yeah, on the screen, whether you have videos going on, or you have brochures of the procedure, or before after images of the procedure. It doesn't have to be only toxin. It can be a mixture of things. So there can be toxin, there can be lasers, there can be hair fall education. Dr. Rajat, you were saying something.
I don't put typically before afters of the patients because many of them are not too fond because their friends will see them and this and that. But if you're concealing identity very well, because sometimes in facial aesthetics that becomes a challenge.
Yeah.
So I don't put it on the main screen outside, but I show it depending on the patient inside inside my chamber.
So there are different ways of looking at this. So that is very important. Second is that I feel that we as a doctor, we have a lot of judgment, like this person may not be able to afford this treatment, or this person may not need this treatment. So a lot of my toxin patients are patients who look like they can't afford it, or who come from a different socio-economic background, or they're a homemaker, or they have come and it's just been that I have had the time, and then whenever they finish talking about their one particular concern, I always ask them, is there anything else you would like to discuss with me today? And when just doing that, saying that I have time for you, I don't need you to leave from my chamber right now, just gives them that space, give them that 30-second break where they can look at something else. Or and when the treatments are going on, like correctly Sir was saying, when the staff is doing one treatment or the doctor is doing a chemical peel, they can talk to them about, would you like to know? It should be phrased in such a way that it is not a hard sell. We say, would you like to know how you would like to improve these lines, which has which is making you look a little tired? Or so words which are like not putting in a way that it appeals to the patient, where the patient says, tell me more. So you are not selling the procedure to them. That is one thing. And yes, social media, please, if you are not already there, please be there already. Everybody who's calling themselves a skinfluencer is there. The real dermatologists have to be there as well, to talk to the people and educate them about this procedure. So because they see you there, they will know that this procedure is available in the clinic, and they will ask you about it. And
I think another important thing, Dr. Asya, is that which I've learned late, is to take regular staff trainings. Because
Yeah,
if
I
your
was coming to
staff is not aware and of the things of what to say, because many a time they are interacting with the patient a lot, you should keep training them and making it better, their dialogue.
Yeah. So I have two things to this. One is that during my treatments, I often get my staff to come in and have a look, right from my receptionist to my the therapists who are coming in along with the junior doctors. So they do get turns to watch me do the procedure. They watch me talk to the patient during the procedure and the post procedure counseling part. So they are aware what to expect and what not to expect. And the second thing which I do a lot is that I do get my junior doctors to inject me toxin on my face and or whatever procedure on my face. So one is, sir, the patients are convinced that the senior doctors allowed the junior doctor to inject her. So, this doctor must be good. So that is one way of telling the patients that, this doctor is a good doctor to get injected from. So my junior doctors have convinced patients in some way. And before, after, sometimes are mine only. So patients are knowing that this doctor has gotten the procedure done herself, and is looking fairly aesthetic. So we will be okay to get injected from her this one. And do not judge. That is what I was trying to. And dealing with complications, a very important part of being a successful practitioner, because you will have complications. Like Rajat said, if you don't have complication, you just didn't do enough cases, and you can handle them. There is a little bit of hand holding. And I think dealing with complications, Dr. Venkatraman sir has written a book about it, how to deal with it, right from all the aspects of dealing with complication of botulinum toxin. Rajat, do you want to add anything here?
I just want to say for whoever is listening that all the complications that you saw in my presentation, all those patients still come to me. So that's just a sign that if you're good to them, they will come to you. I mean, and so just know what you're doing and know what to say.
Correct. And say that I know this has happened and I know how to handle this.
Yeah.
So I will take you through this situation. So I think that will help. And so I'll sign off with.
I think one of the important thing is to not to shrug off our responsibility.
Yeah.
Yes.
And that is something which is very bad. Complication patients invariably come back to you if you have treated them well. They don't mind the complication, but they will not accept bad behavior.
Yeah.
So patient, one has to be extra nice to them, and then they will come back. And as I said, the complications are not common. Even if they happen, it corrects itself. It is self-limiting anyway. So most important is they will be a little angry. They will use certain words which we may not like. After all, they have paid money. They paid money to get better, and they didn't get better. They got worse. So if they are upset, they are upset because that side effect happened, not necessarily at you, but they're going to express it to you. But when they express it, if we take it personally that he's calling me names, he's doing this to me, then we will react in a very adversarial way. That should not happen. We neither should get nervous, nor should we get angry. We should remain calm. And once that happens, once the patient gets the confidence that this doctor will handle my side effect, invariably they become very good patients later. So the complication patient is actually a good thing to have, because he will keep on coming back again and again. So one should not get judgmental about it. You mentioned that you should not judge a patient by the way patient reacts when he or she has got a complication. That's, I think, very important.
Completely
And another thing is that you may sometimes see other doctors' complications. In that time, don't say that is a complication created by that person's poor knowledge. Don't take that doctor down. Explain that what could have possibly happened, and then manage the complication. And if you can, and that is how to hold the patient. Do not bring down your colleagues in front of the patient. That is very, very important. So take home messages.
Now, before that, there are few questions.
Questions are there. Okay.
So shall we just take them?
Yes, sir.
In the nephritity lift, why is it said that the disappearance of the mandibular border on pulling down platysma indicates high possibility of success?
Sir, I answered this in my talk. That's because the platysma pars mandibularis is very active. So if you weaken that or relax that, then you will get, in those patients, get a much better cervicomental angle and a better border.
I think some of these questions you have answered. Now, can topical anesthesia be used
I
prior to
answered
Yes,
this.
yes,
Yes,
answered.
that can be used anywhere, even in the palm hyperhidrosis. Do we have to give anti-spock injection in all cases to prevent spock growth?
Usually, some patients want that flare of the eyebrow, and especially women. In men, almost always I do the anti-spock injections because we want this eyebrow to stay horizontal. But in some women, they like that elevation of the brow. So you can ask them their choice and tell them, if you feel that the eyebrow has lifted too much, you can come back and get it corrected later. But you don't have to do the anti-spock for all women.
A simple way to detect a spock is you knock off the depressor, ask the patient to raise, and you'll see my spock right here. So if some patients won't have a spock like this, some patients will. If you see an excessive spock, it might be a good idea to do a slight dosing. And otherwise, like Dr. Asya said, you may not do it also in many cases.
For frontalis, do we have to restrict to mid-pupillary lines or can we go beyond?
You can go beyond.
Yeah.
Then what is the maximum botulinum toxin that is lethal? I think.
Who's planning to do what with this?
No, this
I
probably
think-
happened very early on. Botox
yeah.
kits, in Africa and all that had happened, but they had happened in while giving it to cerebral palsy children, such children,
Yeah.
when they
Yeah.
gave heat doses. So it's not.
3,000 to 5,000 units, I would say.
Now somebody is asking here, how to treat secondary immunogenicity?
Secondary immunogenicity is very not described in cosmetic injections because of the doses that we use, the smaller doses that we use. If you have a secondary failure of botulinum toxin, we have to look at all the other things. Did your cold chain fail? Did you give the adequate dose of the toxin or not? Did you inject the correct muscle or not? And did the patient actually get the result but is saying that they didn't get a full result? So those are the things you'll have to look at. I think it's extremely rare, and you can change theoretically from to a toxin which has less immunogenicity theoretically.
Does topical botulinum toxin work, or can we use it as a transdermal drug delivery?
I think it has been tried in transdermal drug delivery. So there are some studies which have looked at botulinum toxin being delivered after doing microneedling and after doing tick cell as well. But I think it's a waste of the product which works wonderfully when it's being injected.
And if you can do microneedling, why not inject it only?
Yeah.
Yes. Now, what is the relevance of marking C line for frontalis injection?
What is the
So
C line?
frontalis is basically a muscle which has bidirectional movement. So your upper part of the frontalis moves caudally. When you raise, your hairline comes down, and your lower part moves up. Where they converge is called the C line, which is typically a 40-60 ratio. So if you inject higher up here, higher dosing, and as you come below your convergence line, your dosing should go down so that you don't drop your brow down and you help in a better outcome.
Okay. That's it. Is there any role of neurotoxin in preventing or delaying the development of static lines? I think there is some evidence to say that it does.
Yeah.
Of course.
Yes. Right. I think we have finished all the questions. It has been a very fruitful discussion. I think we have been able to give a wholesome idea to the students. Thanks to all the fellows who presented vertically. Unfortunately, Dr. Aniket could not be here due to a personal issue. And thanks, Dr. Rajat, for excellent presentation as usual.
Thank you,
Thank
sir.
you, Dr. Pasya. Again, very nice presentations. Thank you, both of you, so much. And over to Team Glowderma for their final comments and then announcement of the next program. Thank you.
Thank you so much, all of you, to giving a fruitful lecture on botulinum toxin. So stay tuned for next lecture, which is on 26th of March, 7 p.m. to 9 p.m. And the lecture is on fillers. And the lecture expert is Dr. Aniket sir, Dr. Sukhbir sir, and Dr. Nitin Sethi. So all participants can download their e-certificate with valid email ID. This is the e-certificate for lecture number 2. Please note, recorded version of Venkat series 1, 2, 3, and 4 is available on glowderma.digiconnect.com. Thank you so much, all of you. Thank you.